Hello, my name is Dr. Karel Habig and welcome to the Retrieval environment. Over the next 20 minutes, we'll go through the challenges of the retrieval environment, how it affects decision making, interventions, patient preparation, and the choice of modality. Let's start with a clinical case. Consider that you're being tasked to an inter-hospital transfer of this patient with a self-inflicted stab wound to the chest, 45-minute flight time away. Here you find a 23-year-old male who at the moment is relatively stable with a blood pressure of 110 on 70, a pulse rate of 105, and saturations of 98%. What resuscitation is needed at the referring hospital? What is the appropriate destination for this patient considering the extent of their injuries? How will we secure this patient en route? What risks are posed to staff? And how will we intervene if the patient should deteriorate? What issues need to be considered in terms of logistics, weather, fuel, vehicle choice, oxygen and equipment? A second case now. This is a 63-year-old male with an infective exacerbation of chronic obstructive pulmonary disease who's just been put on non-invasive ventilation, BiPAP, in a small rural emergency department, 45-minute flight time away. Currently they have a respiratory rate of 28, oxygen saturations of 93% on 50% FiO2, a pulse rate of 120 in atrial fibrillation, and a stable blood pressure of 140 on 80. Does this patient need any immediate resuscitation? How will we know that they're going to be stable for the flight? What options do we have in terms of oxygen delivery en route? How will we know that they'll be stable for the flight? What oxygen delivery devices and techniques do we have as options? Can we do BiPAP in the aircraft or road vehicle? And what do we need to consider about oxygen use? This is the most familiar environment to hospital clinicians. In this case, an emergency department resuscitation bay. And this is where we treat most of our very sick patients. The patient comes to us. The environment's safe, or at least with limited personal protection issues. It's air conditioned, clean, well lit. The patient's presented to us at a good height with 360-degree access. We've got plenty of equipment, backups hanging on the wall or in the bay next door. We have piped oxygen supplies, uninterruptible power supplies, plenty of hands to treat the patient. And we have backup, professional expertise and support from other specialties. We have pathology, radiology and other imaging available. So overall, a good place to resuscitate a patient. Let's contrast that now with the pre-hospital and retrieval environments. Now this is the view from inside a four-wheel drive ambulance with an AW139 helicopter hovering overhead with the patient inside the road vehicle. And the challenges and risks of the pre-hospital environment only increase when winching or long line operations are needed. This is a patient being managed in the pre-hospital environment, undergoing a rapid sequence intubation. How different is this from the resuscitation area in the tertiary emergency department? Uncontrolled temperature and environment, dusty, dirty, minimal hands, minimal backup equipment, limited oxygen, limited power. The considerations of managing a sick patient in this environment are many. And here's the back of an ambulance vehicle. Superficially, similar to a hospital, relatively clean and well lit, white walls, air conditioning, piped oxygen, equipment's hanging on the walls, and there's some room to place equipment around. It's just enough room to treat a patient, but certainly a far cry from a hospital resuscitation room. In fact, this is the equivalent space recreated in a hospital resuscitation room. And how many of us would choose to resuscitate a patient here? And here's a patient who's been moved just outside an ambulance. This gives the treating team 360-degree access and recreates some of the ideal features of that emergency department resuscitation room. The art of pre-hospital and retrieval medicine is adapting the environment. Let's go now to the aeromedical environment. This is a patient packaged for transfer from a pre-hospital scene in a small EMS helicopter. The environment is obviously confined. It's extremely noisy. There's absolutely no way that you can hear breath sounds, heart sounds, obstructed noisy breathing. There's a significant amount of vibration, meaning that it's difficult to feel pulses. Oscillometric blood pressure machines don't work, and ECG tracers have significant artifact. It's poorly lit at night due to aviation concerns. It's either cold or really, really hot, and the staff and the patient are exposed to those thermal stresses. There's clearly limited ability to reassess the patient once they're loaded inside the helicopter, strapped in and secured. There's limited ability to troubleshoot equipment should they fail en route. And there's limited ability to intervene on a patient should they deteriorate. This is the AW139 helicopter we saw earlier, a bigger helicopter, seemingly has more space. But with a patient loaded, they really are difficult places to work. And this is the largest civilian EMS helicopter in routine operation. The challenges of working in the aeromedical environment are compounded when patients are very sick or have lots of equipment. You can see here a patient who has an ECMO machine attached, extracorporeal membrane oxygenation, which is heart-lung or lung bypass. Whilst it is possible to transfer patients safely and manage them in the retrieval environment, it requires significant pre-planning and thought. This is the internal cabin of a fixed wing, in this case a King Air. It's a more comfortable environment with less vibration and noise, but still very challenging to manage a sick, critically ill patient. It's clearly confined, there's limited access to at least one side of the patient, and once they're strapped in, secured to the vehicle stretcher, it really is a challenge to assess, troubleshoot, or intervene on a patient en route. Vehicle choice. Typically, we have three main modalities of moving patients in the retrieval environment. We have road vehicles, helicopters, and fixed-wing planes. Vehicle choice is determined by a range of clinical and logistical factors, including distance, weather, accessibility to helipads or landing strips, availability of vehicles, significant patient considerations are the expediency at which the patient needs to be moved. Whilst there are some differences in the working space, noise, vibration, oxygen demands and power, all these environments are actually more similar than they are different. They're difficult environments to assess a patient, troubleshoot, or intervene. There can also be issues with motion sickness and environmental issues that impact on crew as well as patient. This is a New South Wales road ambulance, not purpose designed for inter-hospital transfer of critically ill patients. It's small and relatively cramped, narrow stretchers with significant weight limits. It has plenty of oxygen and IV fluids. It's an all-weather platform, but slow over long distances. This is a helicopter, in this case an AW139. Its big advantage is that it can go pad to patient or pad to pad. It's particularly useful over medium distances, typically around 25 to 250 nautical miles. With a flight speed of between 120 and 160 knots, helicopters are excellent where long distances are involved and speed can help patient care. They don't have to stop for red lights or bad traffic, and they're good for difficult access where they can use winching or long line procedures. Their big disadvantage is that they're susceptible to bad weather. They're unpressurized, they're uncomfortable over very long distances. They're very complex machines with lots of maintenance required to keep them in the air. And they're very expensive, limiting their availability. This is an air ambulance fixed wing. Their advantages are particularly seen on longer distances, greater than 250 nautical miles. They are pressurized, they can control the internal cabin pressure all the way down to sea level. They're generally larger, with less weight constraints and can take multiple patients. G-forces on takeoff and landing can be more severe in a fixed wing, particularly noticeable in hypovolemic hypotensive patients. And their big disadvantage is that they require a landing strip, and so there's usually a rowed leg between both phases of retrieval. Weather. Working in retrieval means you have to have one eye on the weather at all times. Particularly helicopter operations. Weather significantly affects vehicle choice, and helicopters are very sensitive to weather conditions. There are a range of CASA-regulated conditions required for safe flight, and so when the weather closes in, helicopters stay on the ground. The weather affects us in many other ways. Wet weather can affect our patient or our equipment. Bright sunlight requires eye protection for a patient, can make monitors difficult to read, and can impair the ability to intubate the patient due to ambient bright light. Thermal stress can impact on staff and patients, and we need to be mindful of protecting ourselves and the patients from that stress. There'll be much more on altitude physiology in further modules, but helicopters and unpressurized fixed wings expose our patients to the ambient barometric pressure, and so we need to be mindful of transferring patients who have gas-filled spaces that are not draining, and we need to consider the effect on the gas-filled devices that we have in patients. And finally, the hypoxia of altitude can significantly affect our patients, particularly when they're tenuously oxygenating. Some other considerations. This is the most dangerous place for a retrieval, the humble elevator or lift. If you have a long career in retrieval medicine, expect to get stuck in one of them at some point with a patient, and this is the last place you want to be without enough equipment or medications to manage your patient. In our service, we carry a small drop-down emergency airway bag, which contains equipment to manage a patient should we be trapped inside the dreaded lift. Another difficult and dangerous place can be the very small hospital. These places are often very stretched. We've come to retrieve the patient because they're unable to be managed in that small hospital. They may have limited stock, and so if we use their equipment, we may denude that hospital for the next resuscitation. We aim to do everything with our own equipment and make sure that we look after the hospital as well as the patient. So back to the patient described at the start of this presentation. The patient's going to be a challenge in the inter-hospital retrieval environment. We should aggressively manage this patient to ensure they don't deteriorate en route. So in this case, we'd be considering a general anaesthetic to prevent the patient moving and maintain paralysis throughout. We would secure the patient in the stretcher and make sure the knife can't move. We're going to ensure the patient has their pneumothoraxes treated before we transport the patient. And if we need to do a surgical thoracotomy, we need to have planned that before we get in the aircraft. And back to the 63-year-old male with an infective exacerbation of COPD. Certainly we can do BiPAP in a road vehicle, helicopter or fixed wing, but there are significant considerations of oxygen use. We need to ensure that the patient is stable on their therapy before we start, and that may require a period of observation. Other options are to treat the patient just with limited oxygen. Other options that may be tolerated are a fixed oxygen mask, and some patients will need to be intubated, particularly if their clinical course suggests they will deteriorate. So in summary, we've looked at the retrieval environment, the challenges it poses, and how those challenges affect our decision making, interventions we might do beforehand or en route, patient preparation, and choice of modality.